Hi, good evening. Not really a lot that I'm sure probably some of the outpatient providers don't know about, but again, one of our most challenging things is trying to get patients discharged. When we do get them discharged, getting them services on the home health side, whether that's PTOT or home health nursing. Part of that is just the companies may or may not have enough staffing and then insurance issues. But we are trying to do our best to get the patients discharged in a timely manner, in a safe disposition. I think one of the things I could ask the primary cares to help us with is when the patients do come in, and I know you guys try to explain to them, and we do as well, they cannot come and expect to be in the hospital for 1 week or 2 weeks. Today, a family member asked, well, why can't you just keep the patient there until we can figure something out in the family? And it's just not possible. As much as we would like to do so, we can't do it financially. And it's not the right thing for the patients to sit in the hospital. There's just so many things that can occur, complications that they may or may not have come in with. They can fall. We're sitting there giving them meds, can have issues with medications. They can, again, become, acutely ill from things that we're doing that may be unnecessary, especially if a patient gets a little agitated or anxious. We're giving them medications that they normally would not take on an outpatient basis. And so this can lead to other issues down the road. So if you could, just continue to remind your patients and their family that the hospital is an acute care facility. We cannot take care of social issues. We can't keep the patients there until families can figure out if they're medically stable for discharge and there's a viable discharge plan. We have to go ahead and discharge them. As much as we would like to sit and wait and help the families get their ducks in a row, it's just not possible. I think that's about my spiel for tonight.
Okay, thank you, Dr. Robinson. I do want to pause for opportunity for outpatient providers to respond. Certainly one of the key elements of this new format is an opportunity for communication. This challenge to discharging patients is a long-standing one and most likely only going to be solved in whatever way we can as a community together. So we have a number of community providers that maybe haven't joined us in the past that are on this evening. I certainly want to welcome anyone's feedback, input, suggestions as we go along. It doesn't have to be on the spot right now, in response to Dr. Robinson, but certainly the form for this meeting is to have this discussion and find solutions to help both the inpatient side of the equation as well as your side of the equation as you're dealing with families. So I guess the character that I always go to for suggestions and comment and leadership, Dr. McLeod, do you have anything to add?
Not really. I appreciate everything that the hospitalists are working to do. I continue to hear sporadically on discharges and things like that. And I would just encourage the hospitalist group to make use of the secure messaging device that we've got to just ask questions, let us know what's going on, ask any thoughts you've got, updates. It just is a very useful tool for us to do that. I've had 2 patients today say that that their doctors commented that they could not get in touch with me. I was like, that's interesting. My phone never goes off and I'm on my computer all day, every day. So I shouldn't be hard to find. So, but I would just encourage ongoing communication. Okay.
Thank you, Dr. McLeod. And Dr. Robinson, is there barriers that then hospitalists are encountering in trying to communicate discharge or?
I think, Dr. McLeod, you're right. I think part of the issue, and as we've all alluded to and outright said, is communication and not using the modes and means that we have of communication. I've been trying to encourage the use of secure chat, and some hospitals weren't used to it. They got these systems and they're now used to it. I've been trying to get us used to this, to use it to reach out to the providers, to the outpatient primary cares, like Dr. McLeod, Dr. Peace, and others who are on the EPIC system. We're pushing that. Hopefully in the next few months, we can actually start using that more around the hospital. And hopefully as people get used to it within the hospital system, they'll get more used to it, using it with every provider that is available. But I will definitely take that feedback back, Dr. McLeod, and let them know again, please, because our goal actually, if it's even one per week, we're trying to reach out to a primary care. We're starting low, trying to reach out to an outside physician, even one person per week from each team to reach out to an outpatient doctor and say, hey, I have your patient. This is what's going on. Any feedback? We're starting low just so that we don't overwhelm anyone. But you're right. It's right there. There's nothing they have to do. When you sign in, it signs you in, unless you make yourself unavailable or log out. And so I will pass that feedback on to try to ensure that we communicate with you guys. And also be careful what we say to the patients if we actually haven't taken the time to try to reach out to you.
Thank you so much.
So I'm anxious to hear, without calling anyone out, among the community providers who are not on the Epic instance, is there anyone who would like to add to this or add additional questions? Certainly there's a greater ease of access for those that are directly on the Epic installation when it comes to following the patient to the outpatient arena. Hopefully every community provider has Epicare Link to have some ability to see labs and notes of their patients, but I would love to hear at least from one of the community providers on potential challenges that they're facing, or something that maybe we could think about and add to make sure that we're including everyone in this discussion. Anybody?
Yes. So there is a new requirement for getting our DEA numbers. It goes into effect on or after June 27th of this year. So basically, there was this new act. It's called the Medication Access and Training Expansion Act, or MATE Act. You know how we love our acronyms. And so basically, that act was to have physicians and other practitioners do training, and it's to try to combat some of the substance abuse and opiate use disorders, and also to help to educate us more on opiates and substance abuse in and around, and how we're prescribing them. Basically, this act will now go into effect. Before, it's for new DEA numbers and renewals. You have to get an 8-hour training. It doesn't have to be in one sitting. It can be over a period of time, as long as you can show, well, you have to click a button, first of all, to say, yes, you attest that you have done this training. Whenever you do training, you keep your certifications in case you're ever audited by the DEA to say, can you show proof of this training? The good news is once you've done the 8-hour training once, you don't have to do it again. It's just a one-time thing for renewal of your license. There are different CMEs. So if you go onto the AMA Ed Hub, so you go into the AMA website and look at the educations on the hub, you should see different CMEs. There should be a course page on substance use disorders and addiction education. You should click on those, and any of those should help you to qualify towards this 8-hour training. You can also, I think, go on the DEA website or and browse CME activities, or it can take you to a link to help with these CME activities, so you can comply with the 8-hour training. Any questions?
Good.
All right, I wanted to answer Dr. Britt. So it says, does the state CME requirements count on this? It should. If you have I have a South Carolina license, so South Carolina has always required 2 hours of this substance abuse, opiate, some CME for 2 hours to cover for you to renew your license. North Carolina has not, I don't think, put that into place as a requirement as of yet. I think probably coming up to the end of this year, they may do that, having it as a requirement. But if you do any of these, you do get a certificate, and those should count towards the 2 hours. Excuse me, towards the full 8 hours.
Okay, thank you. I don't see any additional questions.